You're listening to Medscape's In Discussion series on Cardiorenal Metabolic Syndrome, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Nihar Desai. Dr. Desai is an associate professor of medicine and vice chief of the section of cardiovascular medicine at Yale University School of Medicine. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Nihar Desai from the Yale School of Medicine. Welcome to Season 1 of the Medscape In Discussion Cardiorenal Metabolic Syndrome podcast series. Today, we're discussing novel therapies, and we're going to focus on the SGLT2 inhibitors. I'm absolutely delighted to have as my expert guest Dr. Jacob Udell. Dr. Udell is a cardiologist within the Department of Medicine at Women's College Hospital and the University Health Network, and a clinician scientist at the Women's College Research Institute and University of Toronto Faculty of Medicine. Dr. Udell's research focus is on cardiovascular outcome studies. He has been a leader in this field, a close friend of mine, and we had similar training paths and overlapped for some time at the TIMI study group. And so I'm absolutely delighted to have Jay with us. It's going to be a terrific session. So Jay, welcome to the Medscape In Discussion podcast.
Thanks, Nihar. Thanks for having me.
So Jay, there's been obviously a lot of interest and a lot of focus on cardiorenal metabolic topics in general. I will say, the other sessions that we've had already in this podcast series, we talked a lot about epidemiology. We talked some about social determinants of health and obviously how they overlap with the rise and the prevalence that we've seen in cardiorenal metabolic conditions. We're going to kind of switch gears, obviously, with you, and we'd like to go deep on the SGLT2 inhibitors. I'd love to get your sense of the history, maybe very quickly for the audience, about how these therapies even came onto the cardiorenal metabolic landscape, because that's, I think, a very interesting part of their development. And then we'll really dive into some of the clinical trials and then some of the recent work that you actually led and was presented at the American College of Cardiology meeting. And so maybe to start off, Jay, give us some sense of the history here for the audience.
So these were developed, again, very early. I think if I remember, the Flozin story even dates back to like the mid 1800s, originally isolated from the bark of the apple tree. I think we've heard Mark Sabatine discuss, the bark of the apple tree a day keeps the doctor away was the initial, tongue-in-cheek saying. And so you'd go to your apothecary in like the Middle Ages, and if you had, a touch of the sugar diabetes, they would shave off a little bit of the bark of the apple tree, and that would be your therapy. Eventually that, several, hundreds of years later is isolated, and they isolate the molecule, the Flozin molecule, and eventually they make some moiety adjustments, and it becomes a drug that's in the development pathway in around the 60s and 70s in experimental models for diabetes. And so how sodium glucose cotransport inhibitors work is that they inhibit this enzyme in the renal tubule that resorbs sodium and glucose, which again, as hunter-gatherer days, was very important for us to retain these essential nutrients when we had a fight or flight and feast or famine environment. But in the scourge of the 21st century of Western lifestyle, we know that, of course, as you've been discussing on your other podcasts, we have an overabundance now of these nutrients that leads to adverse outcomes, including obesity and diabetes. When these inhibitors started to come out, they were being tested because it seemed most obvious that we would now have this first time a therapy that excretes glucose and cause glucosuria, so urination of the glucose molecule, by inhibiting the retention of the glucose in the renal tubule. And so it became a natural therapy to develop in diabetes. And as it came down through phase 2, and then we were at the precipice of one of the phase 3 studies in DECLARE, it became obvious as we were even discussing the outcomes, as you remember, in DECLARE, that it wasn't on initially the radar to study it as a heart failure or therapy that could reduce the risk of heart failure, because its subtle cotransport inhibitor was the sodium. We've thought about this. We know very well that excessive sodium in patients who are at risk for heart failure can tip somebody over the edge and lead to decompensated heart failure. And so excretion and natriuresis, excretion of the sodium, became something that was intriguing to look at even before there was a signal that we had heard about in any of the other diabetes outcome trials that were testing SGLT2s, to think about it as a potential therapy or prevention for heart failure. And I actually remember again Dr. Sabatine coming to my office and asking if we were studying this in the other therapeutic classes of diabetes outcome studies that we were looking at. Really thought that there was something that we might see here, and we had a hunch. And so again, excretion of glucose, which we thought would be good for diabetes, and in that era, which was very much a hot topic, was to look at any diabetes therapy in a cardiovascular outcome study. Again, a generation earlier, we had seen the story of the TCDs increase in the risk for potential CV adverse outcomes, particularly heart failure. And so all of these CV outcome studies were initially designed or being thought of as non-inferiority studies, and we pushed them. Many of us had pushed them to become actually superiority studies for CV benefit. And so the focus really was on that MACE signal and not necessarily in the heart failure signal. But first drug to come out, that initial trial, was the EMPA-REG outcome study. And you remember that was really, kind of caught everyone off guard. It was actually only designed for a non-inferiority study. It was only powered for a non-inferiority study, but it hit on superiority. And it hit on that primary endpoint, was that triple composite of MI, stroke, and CV death. But it really was pushed predominantly by CV death reduction. And it became evident that the secondary endpoint that it really had its substantial impact on was that reduction in heart failure. We didn't really understand how many patients were actually at risk for heart failure. We never captured LVEF in any of our patients. We didn't really have a really good grasp of this was how HFrEF or HFpEF, and that all evolved over the course of the several other subsequent diabetes CV outcome studies. But that pattern kept showing up, that there was a reduction in heart failure, and then it was, sometimes hit, sometimes miss on CV death, and even in EMPA-REG's case, all-cause mortality. By the time 4 CV outcome trials of SGLT2, various SGLT2 inhibitors came out, and if you include SGLT1 and 2 inhibitors in sotagliflozin, there was this consistent signal. It became self-evident that we should really move away from its effect on glucosuria, which really, it wasn't even that effective a diabetic therapy. It has this beautiful self-regulating off switch and turning off of the glucosuria. So you don't see hypoglycemia. You actually see a reduction in that excretion, but you still see that consistent natriuretic effect. That it was then evident that the field moved towards treatment of heart failure. And we saw many then very impressive outcomes, I think even more impressive than many of us were expecting, in the dapagliflozin and empagliflozin studies of heart failure. It was also, evident that we don't exactly know the mechanism, but we feel that there's great, again, pathobiology and mechanistic studies showing that there is this decompression, reduction in intraglomerular hypertension, and we presume also improvement in myocardial handling. And so it was evident as well, especially its effects in the nephron, that it should be studied as a renal preservation therapy. And then we saw many other CKD studies that showed this impressive reduction in progression to end-stage renal disease or dying from renal disease. And so you really see this beautiful arc of cardioendocrine renal risk reduction. And to your point, then we thought, if this stuff works after the disease sets in, perhaps we should even step back and ask the question, perhaps at the time of a large insult like a myocardial infarction, perhaps it could work as well for reduction in prevention of the incident of heart failure in those patients.
It's so interesting to kind of recall those early days. And it was really an FDA mandate, right, for any new, quote, diabetes medicine to be evaluated for cardiovascular safety, just like you said, given what the experience had been with the TZDs and rosiglitazone and kind of on the cardiovascular side. And so from that FDA mandate, if you will, come these therapies that not only show safety, but actually become some of the first therapies on the diabetes side that show cardiovascular benefit. So I want to double click a little bit on that for our audience. Give us your sense of where we are in terms of the SGLT2 inhibitors, which seem, as you kind of rightfully pointed out, almost the poster child for cardiorenal metabolic disease and cardiorenal metabolic syndrome.
They're the ACE inhibitors of the 21st century, hard stop. Drilling down at the pathobiology, the pathomechanism in the nephron and how it affects efferent vasodilation versus afferent vasoconstriction, it really acts as the reciprocal effect of what we see with ACE and ARB inhibition in the nephron. And so it has that same counterbalance in allowing for that decongestion and decompression at the kidney, at the nephron level, that leads to those benefits we think in the kidney. And we think then either directly or indirectly, the same off target mechanism allows for a decompression or a decongestion at the cardiac level. It's been this impressive, as you said, like impressive, consistent signal of effect. And that really has settled down in the heart failure space in terms of its ability to prevent incident and recurrent heart failure. Its effects on other events, it's less consistent. It's certainly a different story than we see with other metabolic therapies like the GLP-1s right now, and likely we're going to see with the GIP and GLP-1 combination therapies. It really seems to be that there's something, particularly with the natriuretic effect, that we see that, there's again other physiological benefits, a slight reduction in blood pressure, again, a slight reduction in weight, a slight reduction in circulating glucose levels, all of which likely contribute to the pleiotropic benefits ultimately. That signal is predominantly heart failure. And then plus or minus the effect on CV death, which is likely all driven from its reduction downstream from heart failure. That signal hasn't been as consistent, but when you meta-analyze the studies, again, it's a modest reduction there, about 10% in CV death, all of which points in the right direction. And it's a beautifully, elegantly simple drug to use. It's not as complicated as many of our other heart failure therapies or many of our other cardiovascular therapies. It's a broad therapeutic safety window, fixed dose therapy with minimal side effects, things that we can very simply treat in the outpatient center, easy to use, easy for the routine clinician. We both have our cardiometabolic clinic that we run at Toronto General Hospital and at Women's College Hospital. And so we have trainees from a spectrum of family medicine all the way to, anesthesiology, nephrology, endocrinology, and cardiology. And everyone feels very comfortable.
It has been such an interesting story there. So as we think about our CRM patients and we think about the SGLT2 inhibitors, yes, they're important from a glucose lowering and as a diabetes medicines, as you very nicely laid out for us, important cardiovascular benefits in terms of ASCVD and heart failure. So maybe we'll sort of round that out and say, take us inside a little bit on the renal protective story. What do we know about the SGLT2 inhibitors for that set of patients?
Initially, the therapies were tested in the most mild CKD outcomes, and we pushed the envelope. Initially there was restrictions on how low you can go in GFR. I remember actually when we were studying these in the diabetes outcome studies, the GFR cutoff when you can implement these therapies were like in the 45 and 50 range. Then we pushed the envelope down into the 35 to 40 range. And then we pushed the envelope all the way down into the 15 to 20 range. And in the trials, if you develop progressive renal disease, there was no mandate to stop the therapies, even all the way down to whether the patient was on dialysis. And so we have really good safety data in implementing and initiating the therapy such that the labels now have reduced the GFR exclusion really, really far down. And that's not a safety reason. It turns out that that's really a concern about effectiveness and efficacy. When the GFR is that low, it's really hard to get the drug into the renal tubule to do its job. It never has shown in any trial of chronic kidney disease patients to be a safety issue to implementing these therapies at a very low GFR. And hence why the protocols have not mandated you stopping those therapies when you cross over and get into a very low GFR. And it has shown, again, a consistent benefit. Each trial has done a slightly different composite of the renal outcome. And so there's been an attempt to kind of harmonize the analyses across trials of a consistent composite renal endpoint. And no matter how you slice it, whether it's a reduction in GFR, whether it's GFR slope, whether it's a progression to stage of kidney disease, whether it's progression to dialysis, whether it's transplant or dying from kidney-related causes, which again has a slight variation in its definition, all of those have been consistently reduced across the different GFRs, across the different spectrums of albuminuria, from macroalbuminuria to microalbuminuria. And again, that simplifies, the effect and the plan in the clinic, right? Because after, again, volunteers of hundreds of thousands of patients across the spectrum of cardiorenal metabolic disease, and again, tens of thousands of investigators and clinic support staff, we really can, in the clinic, really simplify the message.
Yeah, and I think that that's a point that, we can't probably overstate and overemphasize enough is clear benefits, for patients with diabetes, clear benefits for patients that then have, concomitant ASCVD, heart failure, regardless of having diabetes or not.
Yeah, forgot to even mention, regardless of whether they have diabetes or not. Absolutely, it was these trials had some did, but then many didn't mandate that they had diabetes, and that's the beautiful thing. It really unlocks the potential. Absolutely agree.
These therapies and the SGLT2 inhibitors really seem like a part or maybe a magic bullet of sorts that whether your patient has diabetes, whether they have heart failure, whether they have chronic kidney disease, or as too many of the patients that we see now, and I know you as well in Toronto, that have many of these things that are all coming together and interacting with each other. And so to think about the power of a therapy like this that has such important benefits for heart failure, for renal protection, for diabetes, for adverse cardiovascular events more broadly. I mean, I think that really illuminates and highlights the power of a therapy and of a class of medicines like this one and why we're so excited about them.
Well, let me ask you a question. I know you have one for me, but Nihar, is provocative then to ask the question, when we do drug development, perhaps we shouldn't be so myopic and think about these therapies by disease state. Perhaps they're by, again, to your point, that spectrum. Perhaps we should be testing, like, look at the GLP-1 signal as well. It's not necessarily restricted to patients with diabetes. And so perhaps we're unlocking even an approach to the development of these therapies that they should be earlier tested more broadly across the spectrum. Perhaps it has nothing to do with that, tip of the iceberg overt disease that sugar level happens to be over a certain threshold. Perhaps there's metabolic effects that is irrelevant to whether or not you actually need other therapies to control your glucose.
Yeah, Jay, I think that's a great point, and I think dovetails to exactly where I wanted to go, which is, to your credit, having seen all of this, being involved in many of the clinical trials for the SGLT2 inhibitors, I think you were really looking at the frontier and saying, hey, we're seeing these important benefits. Look at what we've discovered about heart failure and CKD and ASCVD and diabetes. What's on the frontier? And I think to your point, then, I think that's really what drove some of the work and the ambition and the aspirations, I should say, of Impact MI. So maybe, tell us quickly about, what the hypothesis of that study was. How did that even come into existence? And then take us through some of the key findings as you guys have started to report out on the study as well.
Yeah, so it had been a while since a new therapy was affecting or was being tested for acute MI that wasn't focused on somewhere along the spectrum of the platelet or the thrombin, and that spectrum of where the insult was along that thromboembolic pathway. If you hearken back to the early days of acute MI care, even before we had antithrombotics, really the effects were focused on these large MIs. Before we even had reperfusion therapies, there was this huge scourge of myocardial injury and resulting in heart failure. And so therapies that can modulate that spectrum along the neurohormonal pathway, or again, myocardial handling, has always seemed to both cross the threshold of benefit for chronic heart failure and then earlier on in acute MI. Now, there have been some clear wins, there have been some that were mixed results, but it seemed obvious, to me at least, after EMPA-REG outcomes came out, that there was an immediate rush to go treat heart failure. But I thought treating MI and preventing heart failure in that patient population might be a very interesting space to go to this again, very safe and usually very tolerable therapy. Some caveats, of course, is that we've had, again, a huge improvement with reperfusion in reducing the overall background risk of large MIs leading to chronic heart failure. And so we were threading a needle a bit to find those sized MIs that were sick enough patients that would be the right patients to potentially benefit, similar to our current therapy of using, let's say, an MRA, spironolactone and eplerenone, in those large MIs that will result in LV dysfunction or congestion and subsequent heart failure. And so that's what we set out to do. We partnered with the manufacturer of empagliflozin, and we did this large trial We initially had humble expectations and a small size, but we really decided to scale this up and to test this properly across multiple countries, international study of 6,500 patients, where a simple question, early initiation after you stabilize a patient with a large acute MI with either congestion at presentation or significant LV dysfunction, and that could be anywhere along the time that they presented. Within the first 14 days, initiate an SGLT2 inhibitor compared to placebo. So again, we saw mixed results. The overall trial, which was powered for the primary endpoint of all-cause mortality or acute, actually incident heart failure hospitalization, had a modest effect that was non-significant, about a 10% risk reduction. Where the action was predominantly on reducing that incident heart failure hospitalization. Again, in retrospect, that is the consistent signal across all the other trials. And then when you look at the totality of data, which we didn't focus on as our primary endpoint, but we look at other heart failure events that occurred, and especially as the timing of when we did this trial was during the height of the COVID-19 pandemic, there was a lot of shift and a further acceleration of treatment of acute heart failure decompensation at the outpatient setting. We found that when you capture those events as well, the totality of the data showed a positive reduction in all-cause mortality and the totality of those incident heart failure events. And so we're digging deeper into the data. We're looking at different particular subgroups of interest. We're looking at the consistency of those results and for any kind of effect modulation, maybe by risk. And we think that this, again, may serve a role, particularly in those who have the most severe MIs when they present themselves. And we think we've helped contribute. And then question, of course, for the our general community and for the guidelines is a reduction in heart failure substantial enough, despite the fact that the all-cause mortality signal wasn't there, to consider this as part of routine practice.
Yeah, no, Jay, thanks. I have to say the adoption and the implementation of the SGLT2 inhibitors has been far too slow and too variable. And so I just want to get your thoughts on what do you think some of the barriers are?
Yeah, I mean, again, you're speaking to both a Canadian practicing but American trained cardiologist. And so you may not be aware, you may be aware that actually dapagliflozin is now generic in Canada, as it is in many, many potential countries now. It's starting to become generic. So we're already seeing that barrier is being reduced. I'll honestly admit that I think, I hate to say it, but I think that there's a gap potentially in the generation that you trained. When I asked my senior colleagues, that was the generation of the HOPE study and the ACE inhibitor and ARB trials. Those were the really hot stuff. And that practitioners and clinicians, generation above them, that was again, a step too far. And it was therapies that they weren't comfortable with. They would recommend it to the primary care provider, but they wouldn't implement it itself. The onus is on us and our generation to implement these ourselves. I mean, you can't again find a more broader, more safe, more efficacious therapy class. I think we're going to see in our training arc in our generation. And so I think it's on us to actually own this space. And so kudos to Medscape and to yourself. Hopefully there'll be other opportunities that we adapt and we adopt and we continue to talk about these, because these are, I think, again, as I said, our generational huge impact in outcomes of care. And we look back again 20, 30 years from now, I think this will be a huge step in a direction of reduction of both hospitalization events and organ damage and mortality in this patient population over the course of the next 30 years.
Yeah, incredibly well said, Jay. And for our audience, of course, we're going to have an entire session on kind of implementation to take us inside that story around, what can we do, where we are, where we're heading. To kind of close us out, my final question, what are you most excited about?
Yeah, so I have to be a little bit careful what I disclose because, obviously it's not all in the public domain, but we're really excited about using novel approaches to risk stratification before it is self-evident that you have a cardiorenal metabolic condition at the earlier stages and initiate and implement a therapy like an SGLT2 inhibitor that can reduce the incident of developing cardiac conditions in the first place or developing renal disease in the first place. The FDA is having, as I understand it, I've never been in the middle of a conversation, but from what I understand, there's been a hesitation to allow for a therapy that treats diabetes historically to be studied to reduce the incidence of diabetes, because you can imagine it's a self-fulfilling prophecy. You're taking a diabetes drug, so do you or don't you really already have diabetes, even if you prevented diabetes. But preventing a cardiac event, incident heart failure, for instance, if this signal has been consistent for all of these other spectrum of illness, why don't we go even to lower risk patients? Now you're going to have to study maybe a larger contingent of patients and find a way again to risk stratify them to find the highest risk patients as a proof of concept. But that would be, I think that's where we're going. And I think that would be a really exciting development as well. And that would really round out the SGLT2 inhibitor story if we're now talking about primary prevention of disease. We hint at it in some of these, as you mentioned. There's that Venn diagram, but really we haven't really touched upon those without any of the conditions that we just discussed, which is the vast majority of all of us. And so, people take statins for primary prevention. And I don't really, and hypertension, I think, is, I guess, probably the other real domain of primary prevention therapies. And this could be the next frontier. But it will take probably public funding to do that. And so that's where we're heading, we hope. And we'll give you hopefully an update in a few years.
Wow. Really exciting stuff, Jay. I mean, think about true public health, population impact. Really exciting stuff. I will just again tell the audience to take a moment to download the Medscape app to listen and subscribe to this podcast series. Thank you again for joining us. And this is Nihar Desai for the Medscape In Discussion Cardiorenal Metabolic Syndrome podcast.
Thanks for listening to Medscape's In Discussion Cardiorenal Metabolic Syndrome podcast series with our host, Dr. Nihar Desai. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on cardiorenal metabolic syndrome.